the plenary. So we're very pleased today to have Dr. Marjorie Meyer with us, and she is a professor at the Department of Obstetrics, Gynecology, and Reproductive Services at the University of Vermont. That really does not do her justice. When you get a chance, please click on her bio in the profile section, and you'll see all the great work she's doing, and I will I'll leave it to her to tell you about some of her additional roles and responsibilities as she talks about her work today. So with that, Dr. Meyer, I'll turn it over to you.
Well, thank you guys. And I was especially glad to hear the introduction from Ms. Hutchins, because I actually learned a lot more about what exactly you guys are doing than I fully understood. And so hopefully this won't be too redundant, but just for a background, I'm a maternal fetal medicine physician. That means that I take care of a lot of medical diseases during pregnancy, not just opioid use disorder. But we use that same lens, right? It's a medical condition that needs to be managed during pregnancy, and really not differently than many other diseases and many other challenges that your pregnant women in your rural areas are going to experience. You'll see a lot of overlap between those chronic diseases and even these maternal outcomes that they talked about. So today, hopefully at the end of this discussion, you'll know how to employ some evidence-based approaches that you can use as you look at women during pregnancy, that you can minimize NAS. And I think that is really, I really actually was glad that people, when I was asked to give this talk, because I had not done a talk with that particular focus before. And so I thought it was particularly helpful. And there are some specific things about rural settings, I think, that are going to be important in the long run. So really, just to come off of, the idea of what Ms. Hutchins was talking about, the reality is that opioid use disorder in rural areas had some very, very specific challenges. First of all, it's obviously where a lot of opioid use disorder and death occur, but also we're always struggling with fewer providers. That includes everybody across the board: primary care, mental health, and medication-assisted treatment providers. But as you look at your pregnant patients, remember that they're struggling with the other part for their obstetric care as well. We know that in rural areas, those women are more likely to experience severe maternal morbidity and mortality. And what that means is some severe complication of their pregnancy, like hemorrhage, stroke, things like that. And rural areas are increasingly lacking in obstetric care. And in fact, it's becoming sort of a national crisis, not that different from opioid use disorder. There are not enough obstetric providers. There are a lot of hospitals that are in rural areas that previously provided obstetric care that have decided not to. So we have women that routinely have to travel a couple of hours at least to just get obstetric care. Many women, if they have a medical complication, need the help of a primary care provider or specialty services. And as you know, those providers are also not necessarily present in your areas. And so when you get to this intersection between these two, when you have someone's pregnant and has opioid use disorder, it just makes that that much more difficult to address. So there's increased opioid use disorder. There's more difficulty in treatment access for both their OB care and their OUD care. And this certainly contributes to increases in neonatal absence. So this is why your work, I can't emphasize enough, I agree, is critically important, because you have a lot of things to pull together for our patients that are pregnant. So this is the overview of approaches that I'm going to go through, and we're going to go through all of these in more detail. We're going to talk about really just prevention on the upfront. I only have a couple slides of this, but I think that it's a super important thing to do, especially as you have rural providers providing care to women, to realize that there might be some strategies to prevent opioid use disorder from developing. We're going to talk about medication-assisted withdrawal or detoxification. I know it's a really appealing approach to reduce the risk of NAS. We're going to talk about where the literature is on that. We're going to talk about evidence-based treatment with methadone and buprenorphine, especially combined buprenorphine naloxone, because I do know that there are some communities that it's way easier to use combined buprenorphine as opposed to single agent buprenorphine. I'm hoping to clarify why you should feel very comfortable using Suboxone or the combination medications. We're going to talk a little bit about smoking reduction and how that relates to NAS. And then last, we're going to talk about harm reduction and just some general treatment barriers. Please use the chat, put your questions there. I promise they'll be answered no matter how it goes. So really, why do women of reproductive age die from substance use disorder? And I think this is just really telling, is that it has to, prescription opioids. And one of the unique things about women is this tendency to start misuse with prescription opioids and for them to be more likely to die. So that's, as you know, and nobody here is surprised that prescription opioids, I do know people have transitioned to heroin and fentanyl, but really prescription opioids remain still a common problem. And why do these women misuse opioids? And here again is where we see a gender difference. Women are more likely to use and misuse opioids to help with emotion and feelings, especially more so than men. And so what happens frequently is they'll start with a prescription for pain relief, recognize that it has an effect on their mood, and then this can sort of help lead into their issues of misuse and then opioid use disorder. Where do they get the opioids from? This also is slightly different than men, but not that different. Still, most of them are social. Many of them come from partners. And also they often start with prescriptions. And again, just speaking to this issue that prescription opioids are more likely in women to be the source of misuse and even overdose. So when we talk about how to minimize opioid use disorder and the development of that is to work with their primary care providers and to recognize when women might be on this bad path of having an initial opioid exposure for acute pain, but then recognizing this modulation of mood and moving on to chronic opioid exposure. Very, very well documented literature on how to avoid this. I didn't go into it here, but limiting the indications for prescribing an opioid. There are many documents put out by the CDC. We were just working on one with chronic pain for chronic pain indications of alternatives to prescribing an opioid to begin with. It's frequently not the best medication for pain. If you do need to do it, limit the number of days and limit the number of MMEs, ideally less than 50 morphine milligram equivalents. That's, I think, now I can't remember, I think it's about 10 oxycodone 5 tablets. Don't refill without an evaluation or an endpoint, and use functional endpoints. I love this idea of referring to a pain specialist, but I also recognize the limitations that we have, that exist in rural communities related to that. But thinking very carefully about opioid prescribing obviously is a first step. So then the next step is, well, we have somebody who's got an opioid use disorder. Where are we now about medically assisted withdrawal and detoxification? I completely understand the theoretical appeal of this approach. No opioids means no NAS. The goal of medically assisted withdrawal is to stabilize women with buprenorphine and then wean them, usually over about 2 weeks, but it could be a little bit longer. The problem is we still have we just have very small trials here. The outcomes have been quite inconsistent, and we really don't have robust long-term maternal outcomes. So actually there are a group of us that were interested in this, and especially Mishka, who's a very smart guy. We basically reviewed the literature, and here's the summation of these studies that specifically look at medically assisted withdrawal or detoxification in pregnancy. And historically, as you know, there was a very big concern about whether or not it was safe to withdraw women, whether or not we were going to make them too sick or not. And I will tell you that in general, any pregnant woman, if they are not acutely ill, can tolerate whatever mild symptoms they have. It's really the issue of withdrawal has to do with how physically ill the mom gets from withdrawal. And so feelings of mild withdrawal that you might get, say, for initiation of buprenorphine, you guys are probably already used to that. Those are very well tolerated. And so this is a summary of the clinical studies that describe detoxification. And these aren't all of them. I just took the biggest ones that were in here. And you can see it's sort of all over the place. There's still a lot of persistent drug use. There are a lot of ones that nobody really could complete their detoxification. There's still persistent NAS that occurred even technically after the detoxification. And I will tell you that probably the study that got the most press was one that had about 300 women in it, but 100 of them were incarcerated and were not even really given an opportunity to talk about how they wanted to be treated in an evidence-based fashion. So, and you can see that the risk for NAS, even in those people that underwent detoxification, ranged even in this study from 17 to 70%. And it really just hones down on what we already know about an abstinence-based approach for opioid use disorder. And that's regardless of pregnancy, which is that relapses are common and it's very difficult to sustain an abstinence-based approach. So the issues of detoxification is it's frequently not successful. People won't even complete it. The relapse rate is high, which really mitigates the benefit of neonatal abstinence. And as we know, when those relapses occur, their mortality is higher. And this illicit use, of course, is more dangerous for the mom and the baby. And we really do need a good trial of assisted withdrawal. And in fact, that trial is ongoing. We're one of the sites there. And it's very much an open label type of an approach where we're offering women medically assisted withdrawal, but allowing them, as things happen, to take their treatment using continuation of their medication or not as they want. And that trial is still ongoing. So where are we right now in terms of detoxification? If patients really want medically assisted withdrawal or detoxification, stabilize them with buprenorphine and then wean them very slowly. I often will have people that come in and ask to be weaned completely or to be detoxed, which is just what their vernacular is. And I say that is totally fine. Let's treat you. Let's get you stable. Let's get you feeling good. And we will get your dose. And as low as we can get it, we'll get it. And I will tell you, most people, as you start to wean them, will decide to hold on a dose and stay there. So if you do have somebody, though, that you do complete with a medically assisted withdrawal on, follow them very carefully. And I specifically tell them that relapses are more likely to be fatal. I make sure they have their naloxone. Of course, I make sure everybody does, but I talk to them very, very specifically about overdose risk if they do that, because it can be so dangerous. So I also know you guys, I think, are pretty experienced. I'm not going to go through everything about methadone versus buprenorphine. You're probably going to know a lot of this already, but I did try and hit the highlights as they related just to neonatal abstinence, other outcomes. And I wanted to go ahead and provide these data on the use of buprenorphine naloxone combination, because I know for me, it is one of the most common questions I get from both patients and providers. And I know that it's sort of still a source of confusion. And, you know, just to remember that the recommended medication, you might go down some checklist that you have or a protocol that will tell you that there is a specific medication that may be recommended for a specific patient. But there may be other factors that are important about access or cost or how to get that medication that might alter which medication you decide to start with. And I wanted to give you that permission to look at the whole patient, not just say their addiction severity index or this or that, but to really give you the permission to not feel like you have to follow every rule. If, say, methadone is better for somebody, but they don't have access to that medication. I know all of you guys have seen these data. This is the Mother study. And there was a randomized double dummy trial of methadone versus buprenorphine. This is just to remind you, it's a relatively small study, not a lot of patients in either arm. But to remind you that the prevalence of NAS was not different between the two groups, but was different was the severity of NAS, and that there was less severe NAS in terms of the amount of morphine the babies required, the duration of hospital stay, and the duration of neonatal abstinence in those moms that were treated with buprenorphine compared to methadone. And this is, of course, still the gold standard, All of us, though, now know, though, that real world data sometimes can differ from the very, very tightly controlled randomized trial data. And I would say that now we also have a good amount of cohort data. I liked this particular study because it looked at methadone versus buprenorphine and neonatal abstinence. It was a cohort study so that it was not as tightly run, obviously, as a trial. People ended up with the medication that seemed to be like a good idea at the time, if you will. And they were all within a single institution. And what I liked about this is they actually, even though they had about 400 women in each group, what these guys did is they pulled out 100 charts in each group to get an idea of addiction severity in methadone versus buprenorphine. And when we did our big cohort study, I recognized that was our biggest limitation. We saw less NAS, but I knew that the women that were getting methadone might have a different addiction severity index and different issues in their addiction than the women that were prescribed buprenorphine. So this study was particularly good at that because they controlled for the severity of their opioid use disorder. And still, even after controlling for that, found that methadone, babies exposed to methadone had about 30% more neonatal abstinence. So, and biochemically, this makes sense when we think about the way withdrawal works in individuals that are on methadone versus individuals on buprenorphine. We know that those two withdrawal clinical symptomatology looks different. So it's not a big stretch that it might look different in babies as well. So there does seem to be more neonatal abstinence symptoms if moms are treated with methadone. Does that mean we should avoid methadone? Absolutely not. Sometimes it is the best drug, sometimes it's the only drug. And remember, safety first. Whatever's the best thing for the mom is going to be the best thing for the baby. So under no circumstances should you avoid methadone, but you should know that if you have a choice, then if you can minimize, if you can use buprenorphine, you can expect a little less neonatal abstinence. So what about other pregnancy outcomes? And this is a great review that Andre Jones did that has a lot more data than these. I just pulled the most two important funnel plots from them. But when you look at the outcomes, otherwise they're the same or slightly better with buprenorphine, but enough to be the same that it would not be a compelling reason to use one over the other. The risk for fetal death is the same. The risk for congenital anomalies is the same. The risk for preterm birth slightly favors buprenorphine. That's what this graph is. This is, again, the summary of all the studies, but not by a tremendous amount. It's not a really big effect size. Birth weight also favors buprenorphine. But in our cohort, we saw that same thing, but we also had slightly longer gestational ages. And if you correct for that 1 week difference, they were still about the same. Again, not a gigantic difference. Head circumference, again, same thing in terms of favoring buprenorphine. And in terms of adverse maternal events, they're not that well recorded in these studies, but they were rare and there was no clear difference. So even when you look at other outcomes, there's not a compelling difference in terms of using methadone versus buprenorphine. Now, what about the use of monotherapy versus combination buprenorphine naloxone? The long story about this was the mother study used a single agent because that was what was being used in Europe. And I'm sure most of you know that it was the FDA that requested that naloxone be added as a deterrent for misuse in the United States. And I even had my anesthesiologist get confused about combined therapy, frankly. But for a long time, the older literature would be like, just go ahead and just use monotherapy in pregnancy because that's kind of just what everybody has done. And what I can tell you now, and I'm going to show you in the next slide, that now a lot of people have used this combined buprenorphine naloxone and it appears to be safe. But I wanted to put this slide up because I think it really tells the most important story about why it's not a big deal. And it has to do with the very minimal amount of naloxone that is absorbed when the Suboxone tablets are used appropriately. So this is here just because it was part of the same thing. This is the buprenorphine dose, which does not matter. This is the naloxone dose that you see when you're administered one Suboxone tablet that has 8 milligrams of bup and 2 milligrams of naloxone. And so here is the plasma concentration of naloxone that you get by using a combined therapy. And you can see here that this dose is somewhere in the vicinity of 0.3, 0.4 nanograms per mil. This is a different publication. If you use intranasal naloxone to reverse somebody, and you give 8 to 16 milligrams, you have naloxone plasma concentrations that are in the 10 to 14 nanogram per milliliter range. These are tenfold, more than tenfold difference in concentration. And even here in this study, because they were curious about it, they gave individuals 16 milligrams of sublingual naloxone as a test. And you can see this is the line right there, like barely, like 1 to 2. And that's 8 times the dose that we have in Suboxone. So the reality is the amount of naloxone is very small. It is hardly absorbed. There are orders of magnitude less dose than in a therapeutic dose. And I didn't put in here that the half-life is very short. It's like just an hour. And the buprenorphine is absorbed much more quickly than the naloxone is. And that's actually why adding the naloxone really doesn't have an effect. And the same is true in pregnancy. So you can use combination in pregnancy. You can use it in breastfeeding as well. I didn't put in a slide for that. But I wanted to just reassure you on the scientific basis upon which when we say it's okay to use it, it really is okay to use it. And here's a systemic view. There's not a huge amount of specific data out there. And we were just starting to pull our data, and then Andre, once again, already published this ahead of me, and I was like, I don't know if it's worth doing anymore. And they looked at clinical outcomes using combined bup-naloxone compared to methadone and found that it was very acceptable in terms of safety. These are all the outcome measures that they used, and that it still, you saw that beneficial effect of using buprenorphine as opposed to methadone. And all the other outcomes were similar. So especially for those of you in areas where it's much easier to use combined buprenorphine naloxone therapy. In fact, most places I know, Andre Jones in North Carolina uses only combined therapy. We only use combined therapy. Most of the large areas are using only combined therapy because it's also easier for the patients to not have to switch back and forth. So I wanted to just reassure you that you can use them. And I'm going to add that even those minuscule amounts of naloxone do not go into breast milk. You 100% can use this medication in women that are breastfeeding, even if their babies are in treatment. We can talk about that later. I didn't put that in here, but I just wanted to reassure you. So it's acceptable to use buprenorphine naloxone as a first-line treatment for opioid use disorder in pregnancy. Absolutely. So this is a summary slide. Some of you guys might have seen it before. I update it very slightly every year. But the other day, somebody was just saying how much they liked it. So I stuck it in here again. And I mostly wanted people to have the permission to use the medication that you think is going to get the patient in treatment, engaged, getting prenatal care, getting them in counseling, anything that will work best for them should really be where you're at. Your optimal medication is going to be based on things other than just their addiction severity, and is often going to be about access to medication. And I just want to call out that especially women, and especially in rural areas, have more barriers to compliance. Being able to get methadone daily is a problem. Childcare is a problem. Transportation, being employed or not employed, all of these things are real barriers to methadone dosing. And so the fact that there are some benefits of methadone is unequivocally true. However, sometimes the best way to start people is whatever it is that you feel that you can get them to use. Another slide I didn't put in here just because it's kind of because there were too many. But I want to tell you that actually in Europe, this study is like 10 years old now, but they used what's called a stepped approach, where they just started everybody on buprenorphine. And then if it didn't work for them, then they just basically escalated to methadone. And those outcomes were just as good as trying to figure out which medication was best on the upfront. So again, I just want to give you the permission to use what will work to bring women into treatment, because what they can use and what they can access is going to be what they can be most, what they can engage in the longest. So the next part in terms of our strategy to reduce NAS from maternal behaviors is smoking. And of all of them, I think this is in some ways the most important, but it's also probably one of the least utilized. And, you know, this remains the best study. It was done, again, as part of the mother study. It doesn't have necessarily a whole bunch of people in it, but they looked at smoking volume that was collected during the mother study. And all they did a lot of fancy biochemical stuff, but they also just asked women, like, how many cigarettes do you smoke a day? And not surprisingly, most of the participants smoked. And they, not surprisingly, on average, a little bit more than a half pack a day. And what they found surprised them a little bit was the self-report of cigarettes that were smoked was actually a really good predictor of the outcome. And sure enough, they just used these average smoking. Women that smoked more, their babies had more withdrawal, symptoms of withdrawal, compared to babies that smoked less. Now, mind you, there were not very many people that didn't smoke, but there's no question, and that's true for the morphine amount needed. It was true for the length of stay, and it was true for needing medications for NAS. So it is really, so it's going to be really hard. You know, I know that women, they're coming in for the initial treatment. It's not so easy to take that conversation and be like, yeah, we're going to deal with your opioid addiction. And by the way, we want you to stop smoking too. We can all realize that that's a conversation that might feel like a bit much for patients. But in the course of pregnancy, I just wanted to remind people that this smoking volume actually also, independently of opioid use disorder, impacts their pregnancy outcome. The more women smoke, the smaller their babies are, they're more likely to deliver preterm, and they're more likely to have neonatal complications. So generally my approach is I let them know that smoking is something that we'll need to talk about, in the future. I acknowledge the fact that I want to get their opioid use symptoms and get them feeling comfortable in a program first. But after that, I let them know we're going to talk about your smoking volume because it's so important in your overall pregnancy outcome. And I know you want to do the best thing for your baby. And I know you're super worried about neonatal abstinence, as everybody probably on this call knows. Women are super worried about this, about NAS independently. And I tell them, here is one thing that you actually can do. And in fact, I'd rather you wean your cigarettes than to try and wean your medication dose. Both of those things, I think, are really important. First, I just have them wean their cigarettes slowly. I don't try and go to abstinence because I feel like that's going to feel like too much for them. So I usually just have them on a slow wean. I'm like, okay, you smoke, 20 cigarettes today, put 19 in your bag for a couple of days, see how that goes, and then go to 18. So I make sure that they know that relationship between their smoking volume and their neonatal outcome is really important. Likewise, I make sure they know that the dose, and this is true of methadone or buprenorphine, I realize there's a little bit of confusion in the literature, but by and large, their dose of their medication is not important in terms of NAS. And so if they were going to decide about which one, their smoking volume or their medication dose, reducing their smoking volume will have a much more impact on their birth weight, their preterm birth weight, and NAS, all three of them, way, way more so than their methadone or buprenorphine dose. So it can be kind of a long conversation, but for smoking in pregnancy, it always is kind of a long conversation, and it's an important one to have. So lower smoking volume is definitely associated with less severe NAS, and it does not matter if they're on methadone or buprenorphine. So we can go into strategies about smoking reduction, but suffice it to say, nothing is terribly better, except for Sarah Heil does great work with incentives, and I think that's always a good talk for another day. But getting their smoking volume down is very important. So when we then kind of go through our general approaches to reduce NAS, here's where the evidence lies. So in terms of reducing illicit use by preventing opioid use disorder in women, there's quite a robust evidence-based approach to minimize the initial opioid prescribing, minimize the dose of any original prescription, minimize the duration of any prescribing, and very, very careful attention to refilling opioid prescriptions. Those are very strongly supported evidence-based approaches to reduce the risk of opioid use in women. The second issue about medication-assisted withdrawal and detoxification. Right now, the evidence does not support using this as an evidence-based treatment approach to reduce NAS, mainly because there is insufficient evidence of safety in terms for the mom or the pregnancy, and nor is there actually evidence of benefit. And so right now, that would not be considered an evidence-based approach to try and reduce NAS. Methadone versus buprenorphine, including buprenorphine naloxone. Here too, the evidence I feel like is pretty good. You can use either. Certainly, this can be a decision that is made on the basis of you as the clinician and their clinical team and the patient. And feel free to use whatever factors are the most important, with the goal being retention and treatment, rather than making sure that, oh, you fit into this box for this medicine or this box for that medicine. The second important thing is do not switch from methadone to buprenorphine to try and reduce NAS. I didn't go into that on this one. Most of you guys are experienced and you know those transitions from methadone to buprenorphine can be tricky. They can be hard to do. It would certainly be reasonable if you have patients that you're already treating that are not pregnant to first have a conversation with them about if they want to be pregnant. And second, if they're on methadone and they're planning a pregnancy, to perhaps then try and do that transition and stuff beforehand. But I would not do it during pregnancy. We don't have enough data, and it's really very tricky to do. Smoking reduction, again, from an evidence-based approach, I certainly would encourage reduction. Acknowledging cessation would be difficult, but it really is just enough. If they can just cut back, they will benefit their baby and their pregnancy outcome. Way, way more important than trying to reduce their dose of medication. So in the next part, we're going to talk about harm reduction. And this has to do with just treatment access, the rural provider, and other methods. I know they talked a little bit about telemedicine before. We're going to talk a little bit about that. So we are the Center for Rural Addiction, by the way. So we do everything through a rural lens. And I just want to, again, bring it back to the experience of women that are living in rural areas. I do not have to tell any of you guys that the issues of rural health disparity are real and well documented. I wanted to add, though, that women are, again, particularly vulnerable. As you know, women do have more healthcare needs in general. And so when you don't have primary care, when you don't have mental health, those things, women can be disproportionately affected. And to remember, again, there's this relative shortage of OBGYNs in rural areas. So it's not even just about their addiction and their mental health and their chronic disease management, which all impacts their pregnancy outcome. It's just, there's not even OBGYN providers or specialty care that are available. This is a paper that was just published on, this is all women, all individuals rather, looking at the treatment for opioid use disorder in individuals with Medicaid. And I think most of you probably know that most pregnant women in rural areas actually have Medicaid coverage. So this is this Medicaid Outcomes Distributed Research Network, which is the modern network. And what these guys did, it's a very interesting research tool that I put up here because I thought you might be interested in it. It included these 11 states. And you can see, I think these are good for looking for opioid use disorder because you can see each of these states has some unique challenges. And it uses the claims data to identify people who have opioid use disorder, and also then to figure out who that have opioid use disorder have prescribed medication for treatment. Now, I'm not suggesting that everybody with a diagnosis of opioid use disorder that's in their claims data necessarily needs medication, but nonetheless, you can see that there is a wide variation. These are all the 11 states, and this is from 2014 to 2018. There's a wide variation of the percent of individuals that are in treatment with a diagnosis of opioid use disorder And it varies from about 35% in this state to about 75% in this state. And this just underscores that access to care is still likely contributing to low treatment rates. Again, I don't have to necessarily tell you guys that, but this is just a nice, gigantic study of a lot of at-risk states that underscore this wide variation in treatment access. So there's a lot we still need to understand better about that. This is another study. As you know, I kind of like maps. So this was another study that looked at the distribution of waivered physicians. So even though over the course of this study, between December 17th and July of 2020, there were more DEA waiver clinicians. And the good news is 63%, if you looked at all the types of rural counties, had at least one waivered physician. But if you looked at especially the small and the more remote rural communities, over half of them lacked any waivered physician. And so basically on this graph, you can see those are the white boxes. And we all know that the prevalence of opioid use disorder is very high in this particular region. And there are a lot of white boxes there. I will add to you this little white box here. This is actually in our catchment area. We're like right over here. And this is an issue here. A lot of people won't treat pregnant women. We're going to talk about that in a minute. But you can see, though, that we still have a very, very significant deficit of providers in rural areas. So I know that in general, we have this idea, okay, you know who's going to save us? As usual, as providers, we know that the ones that save us are our nurses, right? And so similarly, the issue is, okay, well, if we have more mid-level practitioners and more physician assistants, maybe this is going to help. So this was another really nice study that looked at nurse practitioners and physician assistants in rural settings. And this is especially good because in these really, especially the small and isolated settings, these actually are the people that are providing a lot of the primary care. And so they're a super important component of healthcare in rural areas. Perhaps not that surprising, the same barriers that the nurse practitioners and the physician assistants experience in terms of prescribing are very similar to physician prescribers. So they are going to be a super helpful part of our armamentarium, but their barriers are the same. They get resistance from their practice partners. I suspect that many of you guys can relate to that. Lack of backup, but interestingly, not lack of confidence in treatment. They feel very comfortable in terms of treating people, but they just don't have the depth that they need when people need a little bit more help. We know, and I suspect that Dr. Patrick talked about his data about the lack of mental health services and psychosocial supports and all of those community barriers just to recovery that exist. But especially the lack of mental health providers is particularly important when you look at treatment barriers and concern about diversion. And, you know, I am not by any means an expert about diversion. I'm sure you have good talks by people that are experts, but I will tell you that in Vermont, when we rolled out buprenorphine a long time ago, you know, this was back 2008, 2010, there was a tremendous amount of concern about diversion. But I will tell you, as you start treating people more, those issues about diversion, you realize that a lot of diversion happens because there's just not the access to care. And so just be careful about how you balance those concerns about diversion, because oftentimes it's just a reflection of care access. And if you can work on your care access, you can kind of mitigate some of those diversion issues. So this was a systematic review of rural specific barriers in the US. And not surprisingly, there are issues that were seen by the providers and issues that were identified at the patient level. This was actually a pretty good paper, but none of these I think are going to be groundbreaking for what you guys expect. From an availability standpoint from the provider, they're like, well, look, we don't have the capacity or the infrastructure, and we don't have enough specialists to help us when we get into trouble in terms of providing MAT. And we do not have the time or the people or the ability to really coordinate the care that needs to be done. I'm going to talk about the hub and spoke in the next couple slides, so just hold that thought. That is a real issue. That was one of the first ones that we had to deal with in Vermont. In terms of provider accessibility, it was mostly actually just a time access. Really, they were just like, we want to take care of these patients, but they just take up a lot of time. And again, if you can get their care coordination, if you can deal with some of these care coordination and infrastructure things, you can mitigate that time piece. This, though, I think is where we have room to move, and that's the acceptability of treatment. And I think this is actually different from the older literature. This has cropped up in the more recent literature about providers' personal beliefs about use of medications to treat opioid use disorder, and that is especially true in pregnancy. Some people that support it in the non-pregnant patients still are very uncomfortable providing this treatment during pregnancy. Viewing patients who have any substance use disorder with mistrust and not motivated. And I was surprised about this, but there is a lot of concern on the provider side about not following the DEA rules. And I don't have a lot more on that, but I think that that's something that the DEA could pay attention to, because I really feel like they don't mean for their rules to be restrictive. And if you're really worried about it, it might be worth having some conversations with whatever those concerns are with the DEA. From the patient standpoint, again, not particularly surprising. Their issues around availability have to do with both lack of clinics, providers, mental health supports, everything that supports care. They also, not particularly surprising, have issues with just access. They can't get to the appointments. They sometimes have to cross state lines. They just don't have a lot of way to get, if they're not right in the community, to get from A to B. This is the more concerning one to me in terms of accessibility, has to do with cost. You're going to see that in my next slide. But increasingly, some providers, to be able to make sure that they can deal with the amount of extra time it takes, feel that because Medicaid reimbursement is so poor, they insist on doing it as a cash-only business, which is a very difficult feed-forward bad cycle to be in terms of recovery. And so this cash-only issue is definitely a barrier. It's interesting, though, when you look at the acceptability, the patients don't seem to be not wanting treatment, but they are not necessarily offered treatment as much as they feel that they should be. So we definitely have a disconnect in the acceptability of treatment from the way providers are thinking about it compared to the way the patients are thinking about it. So what are some pregnancy-specific barriers to medications for opioid use disorder? These data came from a couple of different papers, but again, you can think about it from the provider lens and from the patient lens. So this was a phone survey. That's what this one was. This was actually Stephen Patrick did this. He might have seen this yesterday about access. Providers that normally prescribe for people were just less likely to accept pregnant patients. This phone survey was one of my more favorite approaches. I call it the secret shopper approach to doing research, where you just call them and say, and ask, you know, do you take pregnant patients or not? You don't tell them you're necessarily doing any surveys. Anyway, when they called medication providers, they found that 91% said, yeah, we take them. But if they said they were pregnant, that number only went down to 75. And that was even true for OTPs, which I was kind of surprised about. Now it's still very high, but 97% said, yep, we're taking patients, but only 91% said yes if they were pregnant. And buprenorphine providers, I think, is where it's the most striking. And I don't know sort of where this is necessarily, and I guess I would like to hear from you guys, because I realize we don't have a huge amount of data on why especially the buprenorphine providers are less likely to accept pregnant patients, but 83% of them accepted patients, but just barely over half would take them during pregnancy. And that, to me, speaks to this difficulty of how you're putting together the difficulty in access of MAT and the difficulty access in OB care, and who's getting nervous about what. I do see that a lot throughout the state of Vermont. So in pregnant patients, and this was a structured interview, and this was in Baltimore, so it's not really a rural thing, but they were really highly motivated to get treatment. They were really concerned about the safety of pregnancy. They definitely have more guilt and shame about having opioid use disorder. They absolutely are scared about loss of custody if they get treatment. And they're worried about losing custody of the kids that they have in their house. They are also very sensitive to stigma from what they perceive from all the providers and even their own addiction community, which was called out specifically. So this is even other individuals that are in their other patients that are in their community. But they feel that basically they feel like they've got stigma coming from everybody. There's a very high rate of violence and homelessness, obviously, and many of their partners have substance use disorder. So this is a big, this is a big challenge. But these can all be barriers to treatment. So who prescribes buprenorphine to pregnant patients? Most is especially in rural areas, which is here in the blue. And as you can see, there's not a huge rural divide here, but I do know that people keep looking to OBGYNs to say, why don't you guys just treat pregnant patients? Well, I didn't show you all the data on the OB rural access, but let me tell you, I know these rural OBGYNs, and they are struggling to make sure that they can just see the OB care. There's usually only one or two of them that work in a community. It is terribly underserved. I think it's great if they can, but I think partnering with primary care is probably going to be it'll be a less big hurdle to overcome. I would love to see more OBGYNs do it. I would love to have them take care, if nothing else, of their own patients. But many of them, it's just going to be one or two people a year. And while I would love to see that more often in rural areas, they are struggling so badly, it's going to be difficult to add something else. So how do we overcome some of the barriers to prescribing? This was a great study that surveyed, it's only 43 physicians, and most of them were, they were in rural areas, and they had large waivers, and almost 60% were in private practice. But here are the barriers and the approaches. Mentoring, using the hub and spoke, that's my next slide, making sure that there's insurance coverage. And sadly, they said that one of their approaches to the barriers of bad insurance was cash only, which is very sad because that is a big issue in terms of access, and using group counseling and allowing people to graduate from counseling. So I think most of you know about the hub and spoke model now. We publish in Vermont. We don't, and basically you have a high risk area with very high intensity, and we send it back to the spokes, which are the primary care practices primarily. And what we did is, as it got rolled out in Vermont, we absolutely were able to increase the number of patients and increase the number of providers with this model. I just added ED starts in here as a reminder. that it can also be done in pregnancy, but not uniformly. But you can see that providing more support can definitely help improve the number of providers. This is what the hub and spoke looks like in pregnancy in Vermont. And it used to be that every patient would come here. We were in Burlington to our high risk clinic. But the bottom line is now every hospital has a program. Women can get treated in their communities way, way easier. We're a small state, but this is still a couple hours drive. And in most of the small areas, the OB and their medication use are separate providers, but these are not big communities. There's only a couple of providers of each one usually. And we do have a mobile methadone clinic. Most of the deliveries occur in level 1 maternal care centers. Anybody that's interested in that, that's basically low risk, and within our low risk nurseries. So most of our patients are able to deliver in their community, which we felt was better from a handoff standpoint. We did a lot of training, and I can talk to anybody about how to expand these things, but it's nice to be able to have people in their community. We do not have a very high rate of transfer to the mom or the neonates related to opioid use disorder, but everybody that has a problem, they come to us in Burlington. California and Washington subsequently have both instituted a hub and spoke model. California, even though they increased their number of prescribers, only about 2/3 of their waiver prescribers were prescribing. And they realized that the people that were not using their waivers just still needed more mentoring and support. And that there still was this provider gap of knowledge and attitudes. I'm coming back to the provider-based stigma for treatment for opioid use disorder. So they did, based on their experiences, have specific recommendations for strengthening the hub and spoke model in terms of mentoring, which honestly, I'm happy to mentor anybody, especially related to pregnancy. I'm part of PSS, expanding support to the spokes. Again, that's what these kinds of things are for, and whatever training and assistance you need. And of course, that's all what CORA does, is to make sure that you guys have the training and assistance you need so that you can do what you need to do. Telehealth is here, and in case you didn't read anything, it's going to help everything. Except for, and this was especially important, we were like, okay, this should help us with transportation, it should help us with the childcare problem, it should help us with access to providers because we can use people that are not so rural, and then we should be able to get our specialty care people because, right, everybody's doing telehealth now, right? Well, it still has a promise. This is an awesome commentary. If you really want to understand telehealth, this is the papers that you should read. It is 100% a great idea. It is going to need some work. They still had issues, as you know, if you live in a state like mine where people don't have web, they don't have cell, they don't have internet, they don't have cell service, and they don't know how to use electronic devices. So that was the first thing that they came up with. So that it didn't really help the transportation thing because people still had to go find those things. Childcare, it's still not going to help. I've had plenty of telehealth visits with the kids in the background. They're not as effective, I can assure you. In terms of getting access to providers that are less rural, they really had, in this feasibility study, they had a lot of difficulty getting people in. I feel like we are probably more experienced with that now, but the patients were not so sure, and it could have been this particular model they used a telemedicine vendor that I think was to help transition them to another opioid use provider, and they were having difficulties with those handoffs. So my point here is, as you talk about telemedicine, be very thoughtful and keep it as local and close as you can, because they had issues with patients just not wanting to accept telemedicine because it felt too distant, and they didn't particularly trust those providers. Specialty care should be a little bit better. It was not really addressed in this trial, and insurance coverage is still actually a problem with telehealth as this transition, as we go out of the pandemic coverage piece, and that's probably going to be state by state dependent. So it's complicated. So these guys, though, this is a great thing. This is just a graph. They do have these potential solutions of how to overcome those barriers. And I just say this is, as you're thinking about a telehealth approach, telehealth is pretty local. So just recognize that it's not like just a one and done kind of a thing. So here are our overview. We've talked about reduction of use, detox, methadone and bupe, and smoking reduction. And here we have harm reduction. And again, patient acceptance of treatment, which actually is, I think, a little better than provider acceptance. Provider acceptance of treatment, especially in pregnancy, I actually think there may be a gap there that we need to probably think a little bit more about. Treatment of mental health comorbidities, this is not news to anybody. And our recovery infrastructure with counseling and childcare and transportation needs to be better. This just is, again, how important socioeconomics are in the opioid use and the infrastructure that's needed for all of those socioeconomic determinants to help recovery. And these basically just have the same kind of data that I put in those other slides. So last, I really can't emphasize enough that whatever you can do to help mom with recovery, to help maternal health, and to stabilize the mom situation, no matter what happens, it absolutely will improve the health of the baby. Regardless of NAS, a healthy mom is more likely to have a healthy baby. So with that, we're going to end this part. I see there are a couple of, not very much in the chat. Feel free to add in whatever questions that you have. We're going to talk about postpartum later. So we have a couple of minutes to go through some of them. And I'm going to just look through the chat and in the 4 minutes kind of go through I think there's just one question up here that was from Sandra. I'm curious about how policy has an effect on the treatment. To give an example, someone decided to stop her medication to avoid the automatic CPS visit. Yes. And that, if you guys haven't asked for a whole discussion on CAPTA, you probably should. Although every state is a little bit different. CAPTA actually shouldn't automatically trigger a CPS visit. And just so for those of you that may not know what that is, I don't remember what the acronym is. Somebody here I'm sure remembers. But basically it has to do with reporting so that people have a sense of to DCF that somebody has a substance use disorder. It doesn't mean that they have to have a visit, but that is highly variable, I'm sure, within state, among states, and it's possible that it's variable even within states. It is super complicated, and I agree with this, Sandra, I agree with the concerns about these policies and how they might impact women's desire for treatment. When we started our program, we spent a lot of time having women trust us that we wanted to make them better. We wanted them to parent. We knew they wanted to parent. We knew they wanted to parent their current kids. And it took some work. And I think that we probably still have some work to do there. Oh, and somebody has a raised hand, which, it's funny because
Hi, Dr. Meyer. If you can, because we have so many people, we just can't open the audio line. So if we have like 1 minute, if you're a fast typer, you could maybe get that question in, or you can, as I'll explain in a minute, you can follow Dr. Meyer into her affinity session and track her down and get your question answered. So I think we do have to move on to that, but I'm hoping if that person can type really, we do have 1 minute. I'm sorry to interrupt Dr. Meyer, but yeah, we're going to do some directing traffic here in a sec. So let's see if that question can come in time. That's fine. Here's okay.
The one thing real quick, were clients okay using that venue? And again, if you read that paper, you'll see that it wasn't the telemedicine per se that was the issue. It was the structure around it. They had trouble accessing the telemedicine. And this particular trial used a third-party vendor that people were not as happy with. I can tell you a lot of us have done telemedicine. There's another, you could do a whole talk on substance use disorder and telemedicine. I actually think patients are pretty used to it now. I don't think there's anything about telemedicine per se. It just needs to be very carefully and thoughtfully put together. You shouldn't just assume that you can flip the switch and everybody is going to be okay with it. But I don't think it was the telemedicine per se that was the issue. But there were a lot of things about the way they structured that particular program that was a concern.